Hi, everybody. It's Adam with HeartValveSurgery.com. And today's a great day for our community because we're coming to you live from the Heart Valve Summit, but it's also our first Facebook Live. Right now, we're beaming across not just the country, but the world, and I'm thrilled to be here with Dr. Eric Roselli.
Hi, Adam.
Great to have you here, Eric.
Great to be here.
And just so everybody knows, Dr. Roselli is the chief of adult cardiac surgery at the Cleveland Clinic. And I can't think of anybody better to start this Facebook Live series with than Dr. Roselli, and I'll tell you why.
We're good friends.
We're really good friends. We've known each other 20 plus years.
It's longer than that. But
yeah, and we actually went to college together at the University of Michigan. So Dr. Roselli, go blue. So maybe we could start this session with maybe all the folks in our community learning about you and your attraction to cardiac surgery and what fascinates you about this incredible work that you do.
Well, that's a question that I've been asked before, and the answer hasn't changed a whole lot, even after being a staff guy for now 13 years, and literally taking care of thousands of patients. There's so many things that make this job wonderful. All the new knowledge, the new technology, the technical aspects of being able to fix a really bad, life-threatening problem. But it still comes down to the best satisfaction I get from the job are, the hugs I get from my patients and their families, knowing that we made a difference in their life. And that's not corny, that's real stuff. So that's what I guess attracted me to being a doctor, and I still get satisfaction from it in this job. I guess going back, I used to have a lot of medical students, and we talk about how you have to make a decision sort of early on whether you kind of want to be a medical or surgical kind of person. And my personality fits surgery. So, I like to work with my hands and like to see kind of immediate results. And I react well in sort of situations where you have to make quick decisions. So that's kind of personal stuff. But then along the way, I realized that in cardiac surgery, we take care of really serious life-threatening problems. And that was the kind of challenge that always sort of attracted me when I was doing my training at the Cleveland Clinic. And that continues to be, one of the personal satisfying things.
Well, I think what you were talking about, the patient connections that you form.
Yeah.
Incredibly special. And just so you know, when we went ahead and posted this, I got a note from Vicki Roberts, who recently her son just came to you and had very successful surgery. Yeah. And she says, Adam, my son is doing great after heart valve surgery. Dr. Roselli did his surgery at Cleveland Clinic. He is a great surgeon.
Oh, that's nice. I've got the best team in the world. It's a team effort, Adam. And so the satisfaction of taking care of people is something that connection is something that you get to actually experience with what you do. So, thanks for that.
Yeah, I always say this is the greatest gift, the greatest blessing to work with this community and work with folks like you who are all coming together for one reason, to help people get healthy. And that is, it's a blessing and a gift.
Yeah, absolutely.
So, we have got...
So we start out with a lot of love in the air here for this talk.
That's
good.
Right.
I'm with you.
Right. I hope all of them go this well and this loving to start.
Yeah.
So, so on the Kumbaya spirit, let's go ahead and get some questions answered here, because we've received from our community over 100 patient questions, and they're fascinating. And the first one, Eric, should I call you Eric or Dr. Roselli?
You call me Eric. We're
okay.
old friends. Yeah.
It's hard to throw the doctor in there.
We're on Facebook Live.
Yeah.
You can call me Eric.
Let's have some fun with it.
Yeah.
So Elizabeth asks, I would like to know the average length of time an artificial valve will last. Mine is from a cow. I realize that all valves are not those. All valves are not those we are born with considered artificial, and that a person's age and health have got to be a factor.
Super important question, and I can answer it simply with sort of the average. The thing I often tell folks, if you go with a biologic prosthesis, that is, what is often referred to as a pig or a cow valve, more and more people are sort of, the trend seems to be going more towards what we call the cow valve. It's not actually a cow's valve. It is a manufactured valve that's made from the tissue around a cow's heart. And that tissue is then processed and it's put together to look kind of like what a native valve looks like. Okay. The answer is somewhere between 10 and 20 years. That's a huge range because there is a broad range for folks. The average is something like 15 years. Some of the things that we know consistently have been shown through many studies that are predictors of how durable the valve will be is how old you are when it goes in. And it's not just because old people are dying. I mean, the statistics account for what we call a competing risk analysis, et cetera. But it seems like the younger you are, the faster the valve wears out. Now that's, something that's been shown over and over again. We did an analysis in Cleveland, the largest analysis ever done on valve durability, where we looked at over 12,000 valve implants over a 20-year period of follow-up. That allowed us to look a little, take one layered sort of deeper dive into assessing what some of the risk factors are for durability of these valves. And it seems as though, and it's not surprising, I think, once we sort of think about it, that it has also a lot to do with how efficient the valve is. So it's important to match the size of the valve to the size of the patient and the stress that the valve, not just your body size, but the size of your heart and the stress that that valve is going to be in when it's sitting inside your heart. We ask a lot of our valves. Our heart beats 100,000 times a day. It's an amazing amount of force that comes. I mean, it's awesome. Okay. So that valve takes a beating. The bigger and more efficient that valve is when we first put it in, and you can see that on echocardiography based on some of the measurements, the better that translates into longer term durability. So in the surgical space, if I'm putting a valve in, I want to make sure I get the biggest valve I can in somebody, especially a younger patient. And I'll even do, a bigger operation like opening the outflow tract of the heart, or replacing the whole aortic root, or even putting a patch in to extend that space so we can get a big enough valve in that we know is going to be durable. And then the cool thing is also, by getting a big valve in, that means you've got space to put a transcatheter valve in at a later date. So those are all things that we're thinking about when we do an operation on somebody. We're not just thinking about kind of the operation that I do. We're thinking about providing one element of lifelong care to somebody.
Very neat. So this is, and I've never heard someone contextualize it this way, Eric. It's almost as if you're thinking about any kind of game. Let's say a baseball game. It sounds like you're coming in for surgery. Maybe it's just the second inning, right? In the care and the progression of care that a patient may need. I think that's fascinating. That's how you guys are planning the patient's therapy.
It's awesome. And as we've gotten more technology in our hands, it's forced all of us to think more about sort of the disease process. So maybe in the future, we'll be actually replacing the valve sooner to prevent some of the changes that happen in the heart that are sort of silent, that we know can affect your lifelong plan. And so it's exciting.
Yeah, and so you talked about something really interesting. I know one of the things our community is fascinated with is the concept of medical technology.
Yeah.
And in the valve space, I look around this room that we're in, and all these these incredible companies are putting out new technology. It seems like regularly.
Oh yeah.
Is there anything, sticking to Elizabeth's question?
Yeah.
Any new technologies that you're seeing might have a possibility of stretching that tissue valve out a couple years?
Yeah, we hope so. So, I'm not going to talk about specific commercial devices. You'll see a lot of stuff online that's promoted by different companies. And I'll tell you, some of these technologies have been developed within the Cleveland Clinic. We have a huge experience and a lot of innovative people. But the important thing to understand about a biologic prosthesis is it's not alive. So we can make it better, but it's still pretty much a tanned piece of leather. And it's going to wear out with time. So a lot of the technology that's been directed at improving the bioprosthesis has been directed at the chemical processes of how that piece of leather is being treated. It's good, it's important, and those chemical processes are key. So we know that the way that you process that pericardium, you take some of the chemicals that are components of cells off of there. You cross-link the proteins. You reduce the attraction to calcium and some of that late degeneration. The mechanics of how the valve is designed, I think, has also allowed the valves to withstand a lot of stress. So a lot of these valves that are currently available, you can stick it in a machine that will mimic millions and millions of cycles of a beating heart, and the valves will last for a billion. There's some studies that have watched these valves for 1 billion cycles, which is decades, and the valves look fine. But we're not putting it into a plastic tube. We're putting it into a human being. And so those biologic processes are where the chemical treatments of the valve are trying to counteract and interact. And so as we understand more about that degenerative process and the mode of failure from a biochemical standpoint, we'll see some of those newer chemical treatments that are directed at improvement. However, even those chemical treatments that we test maybe in an animal model, like implanted into a sheep or something, looks better, but the real test is when it goes into a human being. So we can get excited about what a valve may, new technology might become durable, but until it's been in people for a couple decades, we don't really know.
Right. Well, fascinating discussion, and we've got tons of questions that have come in.
That one probably answered a lot of people's questions.
Oh no, it was fantastic. And so let's keep going on. And this is a question that a lot of our patients struggle with, and it gets to the commonality of the disease aortic stenosis.
Yeah.
And Rich asks, what causes calcification of the aortic valve, and what can be done to prevent it? He also throws in, as it appears to be a Western-based disease.
Not so sure that's totally true.
Yeah.
In the Western world, people live longer. So a lot of the aortic valve disease we see is in older patients, and people only live to be 50 or 60 years old. We didn't see a lot of valve disease unless you were born with a bicuspid valve or something. Now the average lifespan is into the 80s. We see more and more people with it. But it's not just the valve is getting old. It is an active disease process. And as we're understanding what's happening at a microscopic level with really all of the cardiovascular diseases that we treat, I think there's a greater appreciation that it is a degenerative disease. Same is true for aortic aneurysm and atherosclerosis of vessels. So we focus a lot on diet and other things that we hope can make a difference, because we can change our diet. We can change the way we eat and the exposures we have in the environment. But still, pretty much most cardiovascular diseases that we see are probably more than half of what causes them is some sort of genetic vulnerability. So, there's patients who are 100 years old and their aortic valve looks pristine like someone who's 20. And there's people that are, 50, 60, 70 years old that valve, can't believe that it's still actually working when we go to take it out. The calcification is a manifestation of the very late stages of degeneration. So it's not something like your calcium metabolism is off that's causing you to get a calcified valve. It's something that's happened intrinsic to the valve proper itself. And that degenerative process goes on at a really, kind of background level over a period of years. And then ultimately it sort of wears out and then it becomes calcified. Just like if someone has a really old scar, from some wound that's decades old, sometimes it'll calcify. Calcium is just a sign of late stage disease. It's not the calcium is to blame per se.
Got it. So I'm just curious now, when you look at a valve, you go ahead and I don't know if it's transcatheter or if you're looking in surgical, and you see calcium deposits on that valve. These aren't little deposits, correct? No. These are significant.
Like rocks.
Wow.
Big piles of rock.
And then do you ever try to remove the calcium prior to replacing a valve, or is the standard of care something different?
Yeah, so when we do surgery, we try and clean that out and go to as pristine a space as we can to put the valve in. That allows us to have the biggest opening possible, and as I was talking earlier, which we think translates to durability. It may take some of the stress off of the valve, et cetera. So we try to clean it up as much as possible. That's one of the fundamental differences between surgical valve replacement and transcatheter valve replacement. With transcatheter valve replacement, you don't take any of that stuff out. You just kind of jam it out of the way. Incredibly, that works okay for most folks.
Yeah.
But, young patient with a bicuspid valve, or particularly an unusual variant of a bicuspid valve, you're not going to have enough space to get a really good fit. You're better off with an operation where you clean it all out and you start with a clean slate. Some patients have this calcium extend into the muscle of their heart and into the outflow tract. I've got some really cool pictures I'm going to be showing at the meeting today about some of these unusual pathologies.
Yeah, I hope to see that. What time is that?
Yeah, later this afternoon. Yeah, around 1 o'clock or something like that.
I'll be there. So let's keep going. This is something that I know, knowing you for as long as I do. You are just, obviously you're a highly skilled surgeon, incredibly talented, but I know you're a great person. And you have a way to connect with people that is, it's wonderful. You're just a great friend and you're a great person. one of the questions
Thanks,
came
Adam.
in.
Keep asking the questions.
I know we're going,
Yeah.
but it relates to this question, which is all about patient attitude, right?
Oh, I love this question.
And you are, so let's
Yeah.
ask it. Steve asks, and we're starting to get some inflow here of people at the Heart Valve Summit. Does a
Great.
positive attitude from the patient help the recovery?
Oh my God, yes, absolutely, 100%. I'm not sure how to study that scientifically, but I am totally convinced that it absolutely does. No doubt. And I imagine that you could do things like, measure endorphins, and you could probably even measure like a return to exercise capacity based on attitude. We've got a complementary medicine institute at the Cleveland Clinic, and I've talked with our yoga group about implementing some yoga programs. But I mean, there's a lot of things that I think being in the right state of mind make a big difference with how you do it. It's very much been my experience that if somebody goes into something with the right attitude, they do better. So, one of the things I tell my patients, and some, certainly, your experience, you sharing your personal experience post-op is enlightening to a lot of people. It was to me too. But I know this from talking with my patients, and I always tell them beforehand, forgive your body.
That's
Forgive
awesome.
your body.
Yeah, great.
Allow your body to recover. I can tell you that after I cut part of your chest open, whether it's full or mini or, between the ribs, the bone takes 6 weeks to heal, like a bone in a cast and all that stuff. That's biology. That's technical. But after that 6 weeks, when the bone heals, most folks need another about 4 to 6 weeks before they really kind of get their endurance back. That's because you have a whole lot of things to recover from. So when you're having sort of up and down days, on those down days, it's easy to sort of get in a bad place. And that's not, and you have to, and I think it's because you can't set unreal expectations. So if you say, I'm going to forgive my body and let myself just recover for 3 months, I'm going to stay positive. Or if I'm getting down, I tell them, when you're getting down, just remember, Roselli said tomorrow is going to be better.
Yeah.
I'm usually right.
Yeah.
And having that kind of good attitude really makes a big difference.
Yeah. Well, this whole patient attitude, I love how you forgive your body, let your health. I remember my surgeon said to me, just play through it. Everything's going to be fine. You're going to get through this.
Yeah.
And so let's keep moving on. And it's going to get a little louder here now as we're getting more people into this area.
So
we're going to talk.
Need to.
Yeah, we're going to sit up and we're going to go into something that you've been dabbling around, which is Tavor, transcatheter aortic valve replacement.
Sure.
A lot of patients have been asking about Tavor, right?
Yep.
And one of the big questions has been about the progression of indication for FDA approval on Tavor. Gary asks, is Tavor approved for intermediate aortic valve stenosis? Is there an age limit for it? And maybe we start right there.
I don't think that there's a standard age limit, no. And it is approved for intermediate risk. What that definition of intermediate risk is, though, is not perfectly well defined. So a person's own sort of concept of what intermediate risk is may be different than what the doctor sees. And that's why when we evaluate a patient and we try to determine what is the best treatment for them, we try to balance all the limitations of the various treatment options, whether it's surgical or Tavor, and we have a team that brings in the various perspectives of trying to understand what the risks of the different procedures are in the context of each individual patient. So that heart team approach, that valve team approach to sort of making a decision about whether somebody's intermediate risk and whether that Tavor is the right treatment option or not is patient dependent and really physician and physician team dependent.
Mm-hmm. And by the heart team, two quick questions for you. Transcatheter aortic valve replacement. Help the patients out there, if you could. What's the difference of Tavor versus standard? If 30 seconds, if you could explain it to them.
Yeah, so both take a dysfunctional valve and replace it with a functional one in that position inside the top of your heart. The valve's a check valve, one-way valve, keep the blood going in one direction. Okay, so when we do surgical valve replacement, we go directly to that place. We cut that valve out and we put a new one in. We either sew it in or we use a device to fix it and seal it in place. With a transcatheter valve, we get there from a remote location. like from the groin or puncturing an artery out here or something. And so we can't directly fix it in place, and we can't excise or remove the old diseased valve. And so that device is held in place with a stent that sort of pushes the old one out of the way and then starts to work within it.
Uh-huh.
But it sounds really nice to have your valve replaced from a remote location with a puncture in your groin, and it usually is for a lot of folks. But there's real limitations to that. Certain kind of anatomy and what we call morphology, or it's kind of the pattern of your disease, can make that valve not work so well, or potentially might limit how long that valve works. You don't want that. Yeah. If we think you're going to live a long time, and although it's harder to recover from an open operation, a lot of valves we can treat through smaller incisions or less invasive approaches, or a lot of times people have multiple problems going on at the same time. So we have to balance that decision.
Well, it sounds like what you're alluding to, and what I really appreciated is a lot of times patients get focused on high-tech, Tavor, maybe teeny tiny incisions, when in reality what you're really conveying is it's what is the best long-term solution.
Absolutely.
Not just a fix, but a solution for that patient at that time in their life.
Absolutely. Like, what's our goal? What's the goal of what we're trying to achieve? If we want to make you live a really long life with a high quality of life and continue to be involved in all the exercise activities that you do, and you're like a young person with a bicuspid valve, man, we got to think it's really durable, and even think about what might happen if and when that valve wears out, if you go bioprosthesis, etc.
Yeah.
If you're 92 and you just want to kind of, hang out with your great grandkids and continue to participate in life, the way you're doing now, understanding you have some limitations because of your age, well, it'd be really nice if we don't knock you off your feet for a couple of months.
Yeah.
So everybody needs their treatment tailored to their own situation, not just the diseases they bring to the table, but, what the goals of treatment are.
Yeah. Let me ask you, Dr. Roselli, I know your schedule here is packed. Do you have time for another 2 or 3 questions?
Okay. Yeah, I'm good.
So we're going to try and get through the sound. I think we're doing a good job.
Yeah.
But you've referenced a couple things. Bicuspid valves, aortic aneurysms. We haven't talked about those 2 things. I know this falls into your subspecialties at the Cleveland Clinic. So maybe we can ask Audrey's question. And Audrey writes, I have the bicuspid valve. I was born with it. I have an ascending aortic aneurysm between a 4.7 to 4.8. I think she means centimeters. Centimeters?
Yes.
Now I have moderate stenosis. Do you know of anyone who has had surgery with these conditions?
Yeah, I operate on that kind of patient just like her every single day.
Really?
Yeah. Yeah. So in that situation, Audrey, we would probably for now, hard to say without looking at your images, but probably for now, based on the information you gave, with moderate stenosis and what sounds like a moderately sized aneurysm, we'd watch it. What we know is that when we watch folks with, and one or the other is going to progress. The valve is going to become severely stenotic to a point where we need to do something about it, or the aneurysm is going to get big enough that we start to worry about it maybe being at risk for ripping, what we call a dissection, or rupturing. And we want to fix them before that happens.
Yeah.
When we operate on it, we take care of both at the same time. Adding the 2 procedures together does not add any risk as long as you're in a high volume center that's comfortable doing a lot of aortic surgery. In our experience, the risk of death and stroke for combined ascending aortic and aortic valve surgery is consistently less than 1%. Right? So we do about 700 or 800 of those operations a year in Cleveland. We've got a great team. We're very comfortable with it. We tailor that sort of operation to your needs. The 2 things are associated with each other, but they aren't necessarily caused by each other. They probably both had something to do with whatever happened in utero when all that was developing the first trimester. We also have, and I think this is another good piece of data for those of you who are out there that have an aorta between sort of 4.5 and 5 centimeters, and we're watching it. We have pretty good data that we published about 1.5 years ago where we were looking at patients that were in that zone. And the data suggests that there's about a 65% chance within a decade that will progress to need something. So if Audrey, we may very well be watching your valve and your aorta for as much as another 10 years, or maybe next year one or the other is going to get bad enough that your doc's going to say, hey, it's time to do something about it. But when it is time to do something about it, it can be done really safely. And even a lot of these will fix through a mini incision.
Wow. So you do the whole procedure.
It depends on the specifics of how much the aorta is involved and how complex they are. But yeah, a lot of times we'll do it through mini incision.
Well, maybe we put the cart in front of the horse here.
Okay.
We didn't really talk about, for those folks out there, all the patients, my apologies, we didn't talk about what an aneurysm is, right? Obviously, there's heart valves all over the place here.
Yeah.
But can you share a little bit about what an aneurysm is?
Sure.
And what are the potential risks? Because you talk about dissection and rupture, and that sounds very serious to me.
Yeah. So, your heart's a pump. It's got to deliver that blood somehow through your body. The way it does that is through your aorta. And the aorta is a huge blood vessel. It's like, I'm looking at the camera there. It's like that big around, okay? Like the size of the drain pipe under your sink.
Wow.
In normal sized. In people that have bicuspid valves, a lot of people that have a familial predisposition to it, and we're studying it in my lab and trying to understand why these things occur, but there seems to be a growing appreciation that there's probably a lot more people walking around with aneurysms of their aorta than we even know. But in a large percentage of people, in the community, they have an aneurysm. What it means is that instead of that vessel being normal size, it's stretched out, it's enlarged. A lot of folks, I think, kind of have it in their mind when they hear aneurysm that there's something hanging off the side, like a bubble on a tire. That's true for aneurysms that happen in the vessels in your brain. They often call what they call a Barry aneurysm. Aortic aneurysms can happen like that if you're a big time smoker and you've got a bunch of plaque. There's an ulcerated area, but most of the aneurysms that happen in the aorta are what we call a fusiform aneurysm, where it's ballooned out. The good thing about that is we can sort of, just like when you're blowing up a balloon, you can kind of predict when it's getting ready to pop. Okay. When we see a fusiform aneurysm enlarging, we can use the imaging studies that we use to closely look at how big it is and some natural history data that we have to understand when big is too big. Because the forces are more evenly sort of distributed around the walls of that aorta, we kind of know when big is too big. What we're learning is that there's probably some other features about the shape of the aneurysms, and that's a bunch of research that we do using imaging data and these really cool computational tools with big data, what they call machine learning and all this stuff. Really cool stuff. We're trying to be more precise. But an aneurysm can be life-threatening. Yeah. And the good thing is if we find it before it becomes imminently life-threatening, we can repair it really safely. And when we say repair, what we do is we cut that section of aorta out, we replace it with a graft. It looks like a little fire hose when we're done. And it's often associated with aortic valve disease or other valve diseases.
Got it. Now, when you do fix the aorta and you put in the Dacron graft and you're getting it back into a normal, healthy size for the blood to flow through. Yeah. The question, I guess, do you always have to repair the valve or replace the valve? How does that work?
Not necessarily. So if the valve is working perfectly, and the valve that God made is better than anything we've got on the shelf. The living valve is the one we want to keep if it's working well. But sometimes we look at it and we sort of predict, well, it's working okay on the echo, but when you get in there, it's going to wear out in a few years. We decide to sort of preemptively treat it. And that's, again, something we tailor to the patients. Usually we can predict, based on the imaging studies, that is the echo and the CAT scan or MRI, whether a valve is repairable, whether it's salvageable or not. And so, again, we look at even though the two things are often associated, an aneurysm and a valve dysfunction, like in Audrey's case, and we look at each one of those as sort of a potentially independent indicator to get to the operating room. We don't necessarily treat them both if we think one will last. There's a lot of people that will have the aneurysm enlarged, but their bicuspid valve is working really well. We think it'll be more durable than a cow valve on the shelf. We'll leave it alone.
Right.
So come back another day.
Yeah. Well, on that note, Dr. Roselli, Eric, friend,
Adam,
awesome surgeon, someone who changes people's lives.
Yeah, you too.
In our community and around the world. And I just want to thank you for your time today.
Thanks for this opportunity.
Yeah, you don't have to thank me, man. I think it's all for you. I know you're going to be on the podium today here at the Heart Valve Summit.
It's going to be a fun discussion with a whole bunch of experts.
Yeah.
And, thank you to everyone out in the community for jumping on this Facebook Live episode with us and your continued interest. And remember that, when you're asking questions that elicit answers from experts, Adam's team of experts, that you're also helping a lot of other people out there. So thank you. thank you for all of you out there for expanding our knowledge. Knowledge is power.
And on that note, let's wrap it.
Yeah, man. See you.
Thanks so much for your time.
Thanks.
Appreciate it. I'm going to come
Thanks a
watch
lot.
it. All right.
Cool. All right.